السلام عليكم. أحب أشكر جمعية الجراحين على إتاحة هاي الفرصة إنه يانج اوفثالمولوجيست حتى نقدم المحاضرة في هذا يعني الحضور الممتاز. My name is Dr. Saif Ghaith. I'm final year Arabic board resident ophthalmologist in Ibn al-Haytham Teaching Eye Hospital. Our story about two patients, one of a child of a traumatic retinal detachment, had a repair previously and an AC silicone oil was left into or prolapsed into the anterior chamber. And another case of a neglected case of long-term retinal detachment that was neglected, but the patient came for cosmetic reason and also because of the irritation of the band keratopathy. We know band keratopathy is a degenerative process. It is the precipitation of the hydroxyapatite salt because it's the most stable salt of calcium to precipitate in the epithelial basement membrane, the Bowman layer, and the anterior stroma. It's usually precipitate in the center, sparing the periphery because the diseased cornea has a low acid mucopolysaccharide, making the environment more alkaline, and we know calcium likes to precipitate in an alkaline environment. But the limbal vessels in 3 and 9, they buffer this pH. So the calcium does not precipitate near the limbus. Also the Bowman layer stops short. We have holes sometimes in the Bowman in the band keratopathy, and these represent the corneal nerve penetrating the Bowman layer. We all know the causes of band keratopathy, so I don't want to dwell on them. But we have systemic causes, we have local causes, and sometimes even topical drops can lead to band keratopathy. We can get EDTA from multiple sources. We have the disodium EDTA as a powder, and we need to prepare it to 3% or 30 milligram per ml. These powder need to be weighted in a specialized scale, but it can never be a sterile technique. We can have also the dipotassium EDTA as a solution. It is used by our fellow dentists when they treat the root canal of the teeth. And we can prepare it from this commercially available 17% solution, and our concentration needed here is 3.3%. What I use is the laboratory tubes of the CBC. Each tube has K3EDTA or tripotassium EDTA sprayed on the wall, on the inside wall of the tube. So I put 1 cc of a fluid inside each tube in a sterile technique, and use the Wexel to scrape the EDTA from the inner surface of the tube, then transform this fluid from one tube to the other until I get the final concentration. The tube what I use is the 2 ml or 2 milliliter tube, and it has a 3.6 milligram of EDTA, so in total I need 10 tubes. So I need to transfer this fluid from one tube to the next. If we do this maneuver right, we start with 1 cc of a fluid and we will end up with 0.7 ml of a fluid, which is more than enough for one case. We have different tubes. We can use different tubes of different volumes, and each has a different concentration of EDTA. So this video is putting the fluid, scraping the walls, and transferring the fluid from one tube to the next until I get the final concentration. The surgery, after adequate anesthesia, preparing the patient and draping and putting the speculum, first I use a sharp keratom to de-epithelialize the surface over the band keratopathy. Then you will see that I will apply the concentration of K3EDTA on the Wexel, using both the manual removal, manual scraping with the sponge, and also sometimes I just put the Wexel on the surface of the cornea and just wait a few seconds for this calcium salt to become softened. So here I'm just waiting for the calcium to be dissolved. Then I rescrape it. You can see it's easily removed now, or at least easier than before. So I repeated this process multiple times. Um, okay. Okay. So I repeated this process multiple times, switching between the applying of K3EDTA and reapplying the sponge to remove and scrape the corneal epithelium until I'm finally satisfied with the result. The blade I scraped from superior, inferior, nasal, temporal, in all different directions to have as smooth surface as possible. Once I'm satisfied with the result, the ocular surface was thoroughly irrigated, and as you will see, bandage contact lens will be placed, and subconjunctival antibiotic and dexamethasone was injected. So this is the pre-op image of the first patient. We see the opacity of the band keratopathy, and this is the immediate image at the end of the surgery. And this is our next patient. We use the same technique for him. You can see this is the slit lamp video. You can see the clarity of the cornea in just 1 week. Even the bandage contact lens was still in place. And this is the other video of the same patient. And thank you.
Thank you very much. So, Dr. Saif, there is no standard time